again to give you an update on coronary artery disease. The big question is what is an update compared to what? So last year in Munich at the ESC 2012, everybody knows what was there, but what happened after this? And the question is, which congresses have been after the ESC last year, and what kind of presentations should I choose to inform you? So I kind of personally thought I picked up those presentations who changed more or less my daily practice, and I think, so I will focus only on those presentations which I think may have an impact on our everyday work. So the four major meetings after ESC last year are the TCT, AHA, ACC, and of course the EuroPCR. So let's start first with the TCT in October last year, which took place in Miami. The big master of TCT is Greg Stone. That's possibly one of the reasons why he called the study the master trial, because he was the principal investigator. It was an interesting trial focusing on the treatment of patients with STEMI, with ST segment elevation myocardial infarction. The background was that suboptimal reperfusion is achieved often even with very successful stent implantation. So you put in a stent, but there is no reflow or low reflow, and this of course deteriorates the prognosis of the patient because the infarct size is not reduced and the mortality is not reduced. This is why many studies looked at embolic protection, and the MGuard embolic protection stent is a novel device with a mesh behind the stent. So it's not only a stent, it's a mesh behind the stent, kind of keeping the embolus or the thrombus in a prison to prevent it from getting dislocated and swim distally and to even increase infarct size. So this was a randomized trial in patients with STEMI, over 400 patients and 50 sites in 9 countries. The control group was regular stenting compared with the embolic mesh protection stent. The inclusion criteria were standard STEMI patients, I would say so, with a really clear-cut ST segment elevation. In the EKG, patients with bundle branch flock or very complicated lesions were excluded. And here's the result, the primary endpoint. It was a surrogate endpoint, not a clinical endpoint. It was complete ST segment resolution, but we know from many studies that the speed of ST segment resolution in STEMI patients correlates to the prognosis. And these were the results in the MGuard group, and these were the results in the control group. And there was a significant reduction of ST segment elevation, which means an increase of speed of normalization of the ST segment in the MGuard group. So this was a positive trial. The primary endpoint was reached. And there was even a trend, although not significant, but a trend of reduced mortality. We will be very excited to see if this can be translated with a longer follow-up period. So the conclusion of this trial were that in patients with STEMI undergoing emergent PCI, the MGuard MicroNet mesh-covered stent compared to conventional stenting significantly reduced the ST segment elevation. But of course, since this was a surrogate endpoint, EKG endpoint, we need a larger trial with a primary clinical endpoint, which is now underway, called MASTER-2. If we look at the evidence-based medicine score from this trial, this is the evidence-based medicine score. The primary clinical endpoint was, it was not a clinical endpoint, so it gets 0 points. It was not double-blind, of course, 0 points, and so on. So the evidence-based medicine score is 5. It's okay, but again, we need to wait for the results of MASTER-2. The other trial presented at the same meeting was ISA left main 2, randomized trial comparing 2 new generations drug-eluting stents on stenting unprotected left main lesions. These were about 650 patients, and the primary endpoint was a clinical endpoint, major adverse cardiac events. And here are the results. Between those 2 new modern drug-eluting stents, the Resolute and the Xion stent, there was no significant difference. And even stent thrombosis was very low, but also still 1% in patients with left main stenosis, but there was no significant difference between these 2 drug-eluting stents. So the summary was that both the Resolute and the Xion stents provide similar clinical and similar angiographic outcomes at 1 year in these high-risk patients. The evidence-based medicine score of the ISA-left main study was higher, was about 8. This is because the primary endpoint was a clinical endpoint. So let's go to the next meeting, to the American Heart Association in Los Angeles in November last year. And then, of course, the big highlight was the FREEDOM trial presented here. It was a randomized trial comparing diabetic patients, surgery versus stenting. All had multivessel disease, suitable either for stenting or suitable also for surgery, and patients with acute STEMI or cardiogenic shock were excluded. So patients had to be able to be randomized to these two groups. And it's interesting that about over 30,000 patients had to be screened to finally find about 30,000 patients to be eligible for the study. So only about 10% of the everyday population could be enrolled in this important randomized trial. Well, what's important to know is that both groups, here's the drug therapy after 5 years, both groups at 5 years had a very high aspirin usage and still a very high statin usage. So the groups are more or less really good comparable. Well, the results of the primary endpoint were not really fun for interventional cardiologists, because you see here after 1 year, the curve separates significantly, highly significant, with a clear advantage of bypass surgery in these patients. And the absolute difference, so to speak, was almost 8%, so 8 out of 100 patients having a benefit from surgery as compared to stenting. Well, myocardial infarction, the same trend. All-cause mortality, and this is really striking. Mortality, this is a very, very important endpoint, of course, was also significantly different in favor of bypass surgery after 5 years. And all-cause mortality also about an 8% difference. Repeat revascularization, this is no wonder, was significantly higher in the stented patients, but the mortality point is still very important. Stroke, on the other side, was the opposite. There was an increased stroke rate, significantly increased stroke rate in the bypass patients. But if you put together stroke, myocardial infarction, and repeat revascularization, there was a clear advantage for bypass surgery. So the conclusion of that trial was that in patients with diabetes and multivessel disease, coronary bypass surgery should be considered, especially also independent of the syntax score. This is a different discussion. Well, the evidence-based medicine score of this study was very high. It was 9.